think about, well, what's the best way for an adult to learn, and how can I approach this complex topic with this parent? And then you have to look at all the different obstacles too for that particular family. So this is just a little bit of theory about, sorry, music again. It's a little bit of theory about, hopefully, yeah, here it comes, about adult learning. That was a surprise to me. But not to me personally, but other people. I don't remember anything. So what we hear, only 20%. Of what we see. Jordan was cut from high school basketball. What we discussed. So you can see how these theories align with the way that healthcare now is using simulation, even with parents. So now we're incorporating simulation sessions for parents to learn skills and care at home. So you can see how these are the reasons why. Because just talking at them, they're not going to remember it. And then you add more and more sort of sensory stimulation. The same thing for professional development. If I just stood here and talked to you, you would fall asleep and you would remember any of it. But if you throw in some interactive, so for adults, you need interactive activities, you need to get them engaged, you need to have them understand the reason why they're learning it, like how's it going to help me and how's it going to help my patients. So I thought that was really helpful for me to think about when I approach a family and I'm trying to teach them skills and information, what kind of things. It's good to have pictures, it's good to have, if you have a video, we're doing the transplant class now that has some visual and some audio. So these are evidence-based practices, and it's really important so that learning really works. One more. Teach back.
What world is teach back?
Teach back is a way to confirm what your patient understands and what you've explained. It's a great tool that will not only help reduce our readmissions and improve our patient's experience, it improves our patient's comprehension.
I just don't understand. I don't have time to do teach back, and furthermore, what would I get out of it? Plus, I feel like I would be quizzing my patients and putting them on the spot.
hard to believe is that doctors are that dedicated to it. But I don't know, we don't see them teaching as much as maybe in an outpatient setting. So obviously he was a doubting Thomas, but he came around. So we covered all these areas. Quickly we'll look at, we mentioned some of the obstacles and some of the needs of our specific patients and families that create sort of obstacles and difficulties with teaching that make us, we will have to come up with very unique ways of teaching and special ways of teaching, because sometimes the families have a lot of problems. Specifically, sometimes we have kids that are cared for by their grandparents or by a family member who may have their own physical and cognitive problems. We have to think about the age of the patient, like are we going to include them in the teaching? Are they going to be out of the room during the teaching because they're distracting? We have to think about that. If we have teen parents or very young parents, or again, people on the older side, you have to think about how are they going to learn. You think about their support systems. Can they really focus on what you're teaching them? Do they have stressors? Do they have financial problems? Are they worried with their insurance? Do they live very far away? Are there services? There's a lot about their support systems that are going to affect the discharge process. And then again, their psychological status. Are they depressed? Are they anxious? Are they guilty? That can cause a lot of problems with teaching and discharge planning. And then we have a lot of international patients, as we all know. That causes obstacles as far as language. We need to have interpreters available and think about their customs and their beliefs and things that we're not really fully aware of that we understand that could affect the discharge planning. So we have all of these things to think about while we're trying to teach and plan. And we have different resources, thank heavens, to help us with all of that. So I'll quickly just go over things that I discovered. New, exciting, sort of innovative measures that we could use hopefully in the future. Some of them are being used in the hospital now, but these are really great ideas that people have come up with for helping the discharge process and helping just healthcare in general. So telehealth follow-up visits, I know that they're doing those in the short bowel clinic. I don't know if they're doing them regularly for every patient, but I know that they are doing it, as a fairly a routine thing, and the physician and I think the nurses are involved in the telehealth calls. So they do follow-up calls and things like that. And I'm sure someday that it will be in place for inpatient calling, follow-up calls. There has been some, I think urology has used a robot in the homes. I'm not sure if I know there was one doctor doing a study. I think that ended, but I know that there's a lot of work being done with that. And they have a thing called community health coaches that basically can be anybody, a social worker, a case manager, a friend. They can get some training in certain communities to learn how to, check up on people, see what they're doing, see if their meds are being taken correctly, just make sure they're going to their appointments. So sort of lay people that can just help with that whole process. There's a Project Boost that I read about that actually came out of Boston University Medical Center, which really is Boston Medical Center now. They created a whole project, and there's some more information later about that. We see a hospital to retail pharmacy connection here in this hospital, which is great for follow-up with meds and just coordination of complicated medication regimens. So that's going to grow. That's going to get bigger and bigger. So partnerships with churches. So there are some churches that are connecting with primary care doctors in hospitals to help patients have some support and some coaching when they get discharged. Then there's a lot of new software out there. It's more of like a way to standardize the process for the documentation, and so that people are following very standardized process and procedures so that things don't get missed. So there's going to be more and more of that. Okay, and then school health partnerships, which when I was a school nurse, I saw a lot of that. Connections between the school and the PCP, connections between the school and the hospital upon discharge and things like that. So the bottom has the AHRQ website. Again, if you need any resources or anything, or even if you're looking for CEUs, they have some educational programs in there. So just lots of different ways to think outside the box to improve the discharge process and keep patients safe and keep them from coming back. So we have a couple of case studies to go over, and we have a multiple choice quiz. So we could probably start to do that after we take a small break, and we'll go over the case studies and do a quick quiz, but for now we'll take a break. Thank you.